Good afternoon, everyone. On behalf of the Education and Professional Development Committee and New Practitioner Committee, I would like to welcome you all to today's webinar titled When Bacteria Fight Back, a review on gram-negative resistance. We are thrilled to have Dr. Nicole Ondrush and Dr. Nicole Capuli as our guests who will present. Dr. Ondrush earned her BS in Pharmacy Studies and her Doctor of Pharmacy from Western New England University College of Pharmacy and Health Sciences, where she graduated cum laude. Following completion of her Doctor of Pharmacy program, Dr. Ondrush completed her PGY1 pharmacy residency at Upstate University Hospital in Syracuse, New York. In pursuit of her interest in infectious disease, Dr. Ondrush completed her PGY2 infectious diseases pharmacy residency at the Mount Sinai Hospital / Toro College of Pharmacy in New York City, and soon after joined the infectious diseases pharmacy team at the Mount Sinai Hospital. Throughout her pharmacy career, she has provided education through journal article publications and presentations at local, state, and national pharmacy conferences. She has educated other healthcare professionals on the importance of antimicrobial stewardship, antimicrobial agents' role in therapy, and guideline updates. Publication topics include the role of pharmacy students' immunization training curriculum, the utilization of antiretroviral therapy for human immunodeficiency virus in patients with end-stage renal disease, and vancomycin therapeutic drug monitoring. She is passionate about patient care and continuing to advocate for the profession. Her professional interests include gram-negative resistance, infections in immunocompromised hosts, and human immunodeficiency virus antiretroviral therapy. Nicole Capuli completed her bachelor's degree in biology from the College of New Jersey in 2018. She then went out to complete her Doctor of Pharmacy at the Ernest Mario School of Pharmacy at Rutgers University in 2023. Nicole's prior work experience includes serving as a pharmacy technician at Claramas Medical Center in New Jersey. Nicole is now a current PGY1 resident at Montefiore St. Luke's Cornwall Hospital. Her clinical interests include infectious disease, critical care, and internal medicine. Outside of her professional career, Nicole enjoys hiking and playing video games. So we're very excited to start this presentation today, but before we get started, I'd like to share a few quick points. For those who have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that you would like to direct to the speaker, please use the question box or chat option. And the CE code for this program will be provided at the end of the program. Now I'll hand the mic over to Dr. Ondrush.
Thank you for the introduction. And today, Nicole and myself were asked to speak about gram-negative resistance and provide a brief overview of the treatment recommendations. Next slide, please. So both Nicole and I have no conflicts to disclose. So by the end of today's presentation for our pharmacist colleagues, we hope that you'll be able to discuss the problem of drug-resistant infections here in the United States and the importance of antimicrobial stewardship. We would like you to summarize mechanisms of resistance employed by our gram-negative organisms and recognize those potential resistance genes that may be present. And then with all of this information, we will then formulate appropriate empiric and directed regimens to treat infections caused by our drug-resistant gram-negative organisms. And similarly here, we have our learning objectives for our pharmacy technician colleagues. So antimicrobial resistance occurs when bacteria develop the ability to defeat the drugs that are designed to kill them. Our bacteria do not need to be resistant to every antibiotic to be dangerous, as resistance to even one antibiotic can cause serious problems. So resistant infections can be difficult and sometimes impossible to treat, and this is making it an urgent global public health threat. So worldwide, at least 1.2 million people die each year due to antimicrobial resistant infections. And here in the United States, about 3 million antimicrobial resistant infections occur each year, which results in approximately 35,000 deaths per year per the CDC. There are 6 highly virulent pathogens classified by the CDC and the World Health Organization, also known as our escape pathogens, that account for substantial healthcare costs due to their resistance to antimicrobials that continues to grow. So our escape pathogens consist of the vancomycin-resistant Enterococcus, our carbapenem-resistant Acinetobacter, our methicillin-resistant Staphylococcus aureus, our carbapenem-resistant Enterobacterales, our extended spectrum beta-lactamase producing isolates, as well as our multi-drug resistant Pseudomonas aeruginosa. So millions of people in the United States receive care that can be complicated by bacterial infections. So without appropriate antimicrobial treatment, we may not be able to safely offer these patients medical care. So at least 1.7 million adults each year develop sepsis. And this is a condition where we all know that the timing and the choice of our empiric antimicrobial agents is critical in improving our patient outcomes. As every hour an antibiotic is delayed, mortality can increase by 7%. A large percent of our patient population, more than 30 million patients, are living with diabetes, a disease state that increases a patient's risk for infection. And then more than 30,000 organ transplants were performed in the year 2016, where these patients are specifically vulnerable to infection due to all of their immunosuppressive medications they receive. And lastly, more than about 500,000 patients receive dialysis treatment, where these patients are at high risk for infection given their chronic line placement. So without appropriate antibiotics, we might not be able to offer appropriate care to a majority of our patients. So since the discovery of penicillin over 90 years ago, bacteria have continued to develop novel types of resistance, even our most powerful antibiotic agents. So types of resistance continue to evolve rapidly, even after the approval and the release of novel antimicrobials. So for example, vancomycin was released a little before 1960. And then about 30 years later in 1988, we can see vancomycin resistance begin to develop. So these organisms are beginning to fight back at our antimicrobials that we've been giving them. And in some instances, the organisms have actually defeated our antibiotics, and this requires new antibiotic agents to be developed. So unfortunately, new antibiotic agents being approved by the FDA have been declining in the recent years. So the development of new antibiotic agents has been hindered by the failure of the healthcare system to adequately recognize and compensate for our antimicrobial agents. There was actually a report published in 2020 that I reviewed, and it discussed 44 antibacterial candidates in the pipeline, which 44 antibiotics seems like a large number, and I think I'd be happy to have 44 new antibiotics. However, when reading further, this was compared to the number of oncologic candidates in the pipeline, and there was a total of 158 drugs being studied just for breast cancer alone. So we have a significant need for novel antibiotics. So not only is this a time-consuming process, as the FDA approval process can take up to 7 years, but there's also a financial consideration. And it's estimated to cost about $1.3 million to bring a new antibiotic agent to market. So many of these larger pharmaceutical manufacturers have lost interest in developing novel antibiotics and have moved to different drug classes. And this has left the antimicrobial market to our smaller, medium-sized companies. So with the growing antimicrobial resistance and the need for novel antimicrobial agents to fight these organisms, what has the United States done for us? So beginning in 2013, the CDC released its first edition of the Antimicrobial Resistance Threat Report. And this looks at the burden that's posed by resistance, and it prompted governmental action. So here in 2014, the White House released the United States National Strategy for Combating Antibiotic-Resistant Bacteria, or the CARB, which was a 5-year plan, where federal agencies were then directed to implement recommendations in order to achieve 5 goals. Later that year, the CDC also released the core elements of hospital antimicrobial stewardship programs, which provided guidance to institutions on how they can operate and create an antimicrobial stewardship program. A few years later, the CDC then launched the Antimicrobial Use and Resistance Module through the National Healthcare Safety Network, or NHSN. And this is used for facilities to report their antibiotic use as well as resistance data in order to use as a benchmark for other institutions. And most recently, the 2020-2025 5-year plan was released, and this builded off the 2015-2020 plan with strategies implementing infection prevention, as well as improve antibiotic use. So as I just talked about, the CDC Antimicrobial Resistance Threat Report, this is the most recent edition that was released in 2018. So organisms are either classified as urgent, serious, or concerning threats. And here we can see in bold 4 organisms: our carbapenem-resistant Acinetobacter, our carbapenem-resistant Enterobacterales, and our extended spectrum producing Enterobacterales, and our multi-drug resistant Pseudomonas aeruginosa. So these 4 we will be discussing today about the potential treatment options we have for these agents. So unfortunately, the pandemic has pushed healthcare facilities to the near breaking points, where we saw a significant increase in antimicrobial use, and we saw difficulty implementing our infection prevention strategies. And unfortunately, all of this resulted in increased healthcare-associated antimicrobial resistance. So within the first year of the pandemic, we saw a large number of patients receiving an antimicrobial in about 80% of our patients. So on the slide here, we can see a few organisms and their resistance trends post-pandemic. So looking at the first graph, we have our carbapenem-resistant Enterobacterales, where we see a 35% increase in hospital onset CRE cases and overall an increase in drug-resistant cases. Looking at our ESBL-producing Enterobacterales, we also see an increase in the number of overall drug-resistant cases and a slight increase in our hospital onset cases. And then lastly, for multi-drug resistant Pseudomonas, we see a drastic increase in our hospital onset at 32%, as well as overall drug-resistant cases. And then just switching gears and talking about a different patient population. So here in the United States, our patient population continues to grow, and worldwide people are living longer. And we know our older adults are particularly vulnerable to infection, so the impact of resistance can be detrimental to them. So there was a study published in 2022 in Clinical Infectious Diseases that demonstrated the rates of 30-day mortality and the average treatment costs associated with those 6 escape pathogens. So on the left-hand side of the slide, we can see the graphs for the unadjusted mean hospitalization costs associated with patients. So on the y-axis, this is the median hospitalization cost, and on the x-axis, we have our organism. So for hospital onset infections, healthcare costs were much higher, especially for our carbapenem-resistant Acinetobacter, our carbapenem-resistant Enterobacterales, and our multi-drug resistant Pseudomonas, which all surpass $100,000. On the right-hand side of the slide, we can see the graphs that look at the probability of 30-day mortality. Probabilities on the y-axis, and on the x-axis, we have our organisms. So as like with the mean hospital costs, we see large increases in the probability of mortality in those with CRE, carbapenem-resistant Acinetobacter, or multi-drug resistant Pseudomonas infection. And this is all likely due to limited treatment options we have for these organisms, in addition to the high cost of those limited treatment options. So antimicrobial stewardship is crucial. It has been shown to improve patient outcomes. It reduces rates of adverse events, including C. diff infection, has shown improvement in antibiotic susceptibility rates, and has optimized healthcare resources. So now that we've highlighted the growing antimicrobial resistance threat and how critical antimicrobial stewardship is at institutions, I'm going to pass it off to Nicole C. to start our review of the gram-negative resistance and our potential treatment options.
Hi, everyone. My name is Nicole C., and I will go over the IDSA treatment guidance document along with Nicole for the treatment of antimicrobial resistant gram-negative infections. So like Nicole mentioned before, she did point out some of the organisms we'll go over. I will be going over ESBL, carbapenem-resistant Acinetobacter, and Stenotrophomonas, and then Nicole will be going over AMC beta-lactamases, carbapenem-resistant Enterobacterales, and DTR Pseudomonas. But before we get into the treatments, we should understand the diverse mechanisms of resistance that have evolved over time to effectively counter antibiotics. And one of the ways that microbes can be resistant is through limiting drug uptake. So for example, the way the drugs can enter the the microbes through pore channels, the antimicrobials, the microbes could actually reduce the number of porins, and they can also change their cell wall properties. Microbes can also modify their drug targets. So for drugs that target the penicillin binding proteins, they can alter that so that drugs can no longer bind to it. They could also mutate the active site of their enzyme. In case the drug binds to that active site, they can no longer bind to it because of the mutations. There's also drug inactivation. So there's an enzyme that we all know called beta-lactamases, and those enzymes actually work by hydrolyzing the beta-lactam ring, opening the beta-lactam and rendering the drug inactive. Another way to inactivate the drug is through a chemical group transfer. And lastly, we have active efflux pumps, and this works by the microbe actually pumping the drug out of its system, and this could be either constitutively expressed or induced through environmental stimuli or other active substrates. And the most common cause of beta-lactam resistance among the Enterobacterialis group is actually beta-lactamases. So beta-lactamases can be encoded either intrinsically on chromosomal genes, or they can be acquired through mobile genetic elements like plasmids. And all of these lead to inactivation of the drug mechanism. Now, over 1,000 beta-lactamases have been described. And one way we can organize the beta-lactamase is to group them together based on function. So what we have here is called the Ambler classification. And this is basically 4 groups, A, B, C, and D. And so for group A, the beta-lactamases that we normally see from group A are ESBLs and KPCs, but also includes other genes, and they hydrolyze more narrow and extended spectrum beta-lactams, penicillins, and carbapenems. And on the right, we see the genes that are associated with that beta-lactamase. Next, we have metallo-beta-lactamases, and these are a scarier group of beta-lactamases, and they hydrolyze carbapenems. The genes associated are VIM, IMP, and NDM, and they're called metallo-beta-lactamases because they have a metal ion attached to it, or in the active site. Then we have cephalosporinases. This is group C, and these hydrolyze cephamycin. So what's associated with cephalosporinases is AMP-C. And lastly, we have oxotype enzymes. This is class D, and this hydrolyzes oxacillin and carbapenems, and you would see OXA with this. So for the first assessment question, which of the following are impacted by the emergence of antimicrobial resistance? Is it financial costs, treatment regimens, patient outcomes, or all of the above? We cannot. Is everyone able to vote? Oh, okay. Yes, correct. It is all of the above. Very good. Okay. So now we'll first go into the first group called extended spectrum beta-lactamases, or ESBLs. So ESBLs are beta-lactamases that confer resistance to penicillins, first, second, and third generation cephalosporins, as well as A strain M. And ESBLs are a growing problem. There has been a 53% increase from 2012 to 2017. And the most common gene associated with this ESBL is called CTXM. And other variants could also include SHV and TEM. Now, any gram-negative has the potential to harbor ESBL genes, and some common examples could be E. coli, Kleb pneumoniae, Kleb oxytoca, or Proteus mirabilis. And if you see non-susceptibility to third generation cephalosporins, this could be used as a proxy to tell if the bacteria has ESBL production. Now, once you figure out that the organism is ESBL, you want to check where the infection is. So if it's just uncomplicated cystitis, if the bug is susceptible to nitrofurantoin and bacterium, it's recommended to use any of those. But if the treatment is complicated cystitis or pyelonephritis, then it's recommended to do carbapenems, fluoroquinolones, and Bactrim. For infections outside of the urinary tract, you would just go straight to carbapenems. But for infections outside of the urinary tract, if susceptibility to Zosyn is demonstrated, Zosyn is still not recommended. And the reason for this is because of this landmark trial called the Marino trial. And this was a landmark study that looked at Zosyn and ESBL in adults with at least one positive culture for E. coli and Clem pneumoniae that was not susceptible to ceftriaxone, but susceptible to Zosyn. Zosyn, compared to Marum, did not result in a non-inferior 30-day mortality. So for ESBL and bacteremia, Zosyn is not a good agent because Zosyn mortality was seen to be higher. As you can see, Zosyn had 12% mortality compared to Marum, which had 3% mortality. You would not use Zosyn outside the urinary tract for ESBL infections. Now transitioning over into other alternative treatments, a retrospective study delves into the treatment of ESBL UTI, and the study did include pyelonephritis and catheter-associated UTI. And this explored the utility of a carbapenem-sparing agent, cefepime. And cefepime is known to be primarily renally eliminated, and urinary concentrations of cefepime have shown to be higher than the MIC for ESBL and Enterobacter. So in a study that looked at patients with symptomatic UTI who received at least 48 hours of cefepime or carbapenem, we see that there were no patients that had clinical or microbiology failure. However, in terms of relapse, we do see some rates of relapse in the carbapenem group, but not the cefepime group. So while cefepime may be suboptimal for ESBL bacteremia, it may be a suitable alternative for ESBL UTI. So for patient case number 1, you receive this page from a medical resident. Hi, can I change this patient to ceftriaxone, or do you have any additional streamline recommendations? So it looks like your species here is Enterobacter cloacae. It's resistant to ampicillin and Zosyn, but it's susceptible to cefepime, ceftazidime, ceftriaxone, and Marum. So would you want to switch this over to Rocephin? Or like, what would you do? Okay. Let's see. Okay, so the answer is no, you would not switch them over to ceftriaxone because like we mentioned before, ESBL Enterobacter could actually be resistant to 3rd generation cephalosporin. So the answer here would be meropenem. And now we'll switch gears over to Nicole to talk about AMP-C beta lactamases.
All right, thank you. And now we're going to talk about that previous case that we just went over about organisms that can cause AMP-C production. So next slide, please. So AMP-C is a type of beta-lactamase that can rapidly hydrolyze our penicillins, our cephalosporins, and our monobactams. And AMP-C is not significantly inhibited by our beta-lactamase inhibitors. So there's 3 modes that AMP-C beta-lactamases can exert its effect, either through inducible chromosomal resistance, non-inducible chromosomal resistance, or plasmid-mediated AMP-C resistance. So for inducible chromosomal resistance, exposure to a beta-lactam agent, such as our 3rd generation cephalosporins, such as ceftriaxone and ceftazidime, will cause an increased production in AMP-C enzymes to be developed, causing resistance to develop on therapy. For both our non-inducible chromosomal resistance and our plasmid-mediated AMP-C resistance, resistance here is constitutive, and AMP-C will always be expressed. So in vitro, you will see non-susceptibility to your third-generation cephalosporins. So here we see our space and spice organisms, which consist of our Serratia, our Pseudomonas aeruginosa, our indole-positive Proteus, Acinetobacter, or Citrobacter, and our Enterobacter. So are all of our space and spice organisms equal in their AMP-C production as we previously thought they harbor our AMP-Cs? So per new in vitro, as well as clinical reports that have been coming out, along with the IDSA guidance document that was published a few years ago, reports are suggesting clinically significant AMP-C production occurs in less than 5% of the space and spice organisms. Next slide, please. On the other hand, for our Enterobacter cliquiae, Klebsiella aerugines, and Citrobacter frundii, these are now classified as moderate to high risk for clinically significant AMP-C production, where these clinical reports suggest the emergence of resistance after exposure to a beta-lactam agent, such as our third-generation cephalosporins, that can occur in up to 40% of infections caused by these organisms. So for our moderate to high risk for clinically significant AMP-C production, we're going to move away from space and spice and start to forget that acronym. And we're going to start moving to heck yes for our AMP-C producing organisms. So this new acronym includes our Hafnia, our Enterobacter cliquiae, Citrobacter frundii, Klebsiella aerugines, and our Yersinia. So based on the in vitro and clinical reports, when these agents are recovered in cultures, the IDSA suggests avoiding treatment with those third-generation cephalosporins, such as ceftriaxone and ceftazidime, even if it tests susceptible to the agent initially, as we know that these can induce chromosomal resistance that can lead to resistance developing while the patient is on therapy. So as mentioned previously, our third-generation cephalosporins should be avoided with our heck yes organisms due to the potential for resistance to develop while on therapy. So treatment options can include cefepime when the MIC is less than or equal to 2. And historically, the carbapenems have been the gold standard. But here, they're recommended when the cefepime MIC is high, as ESBL co-production can be present. Additional options include fluoroquinolones and trimethylprim sulfamethoxazole or Bactrim. So as mentioned, our carbapenems historically were our gold standard for AMP-C beta-lactamase producing organisms. However, there's a retrospective study that looked at approximately 300 patients with Enterobacter cliquiae bloodstream infections, where they compared cefepime to a carbapenem. And here they used imipenem, meropenem, and ertapenem. And here we can see on the graph on the right-hand side of the screen, the probability of survival on the y-axis and the time in days on the x-axis. Advance the slide, please. So here we can see that the outcomes varied by MIC values. So for our top line in this graphic, we have cefepime susceptible, which was defined as an MIC to cefepime of less than or equal to 2. Versus cefepime susceptible dose dependent, which is our bottom dotted line in this graph, we see that this occurred when our isolates had an MIC to cefepime of greater than to equal to 4. In the middle lines of the graph, we can see those isolates that were treated with carbapenems. So based on the results from this retrospective study, cefepime is suggested for the treatment of our heck yes organisms when the MIC is less than or equal to 2. And a carbapenem is recommended when the MIC to cefepime is greater than or equal to 4, as co-ESBL production can be present in these outcomes. And when comparing cefepime to the carbapenem here, we see that there was a similar prognosis, as well as when utilizing a high-dose cefepime regimen, so when utilizing 2 grams IV Q8, so optimizing those pharmacokinetics and dynamics, we saw that there were better outcomes compared to other dosing. Next slide, please. All right, so this brings us into our next polling question for patient case number 2. So we have an 80-year-old man who's presenting with no known drug allergies, presenting to your institution with complaints of abdominal pain, chills, and GI upset. So blood cultures are obtained and the gram stain is revealing gram-negative bacilli. And we now see the susceptibilities listed here on the slide. The patient's been receiving piperacillin tazobactam, 3.375 grams IVQ6. And based on the susceptibilities, what recommendation would you make to his regimen? Okay, so we have a majority of votes for our ertapenem and our meropenem. So here we can see, looking at the susceptibility profile for E. coli, our ceftriaxone is deemed resistant. So this could be utilized as a proxy for ESBL production. So we know that this patient has ESBL E. coli growing in his blood. So we shouldn't be using options B or C, as in the Marino trial, there was higher mortality rates in patients who received Zosyn in comparison to a carbapenem. Here, choice A, is incorrect, as cefepime is resistant, so we would not want to use that. And choice D and E are both carbapenem agents, so they are not one. So the choice of meropenem is not incorrect. However, here the choice D, recommend switch to ertapenem, would be the most appropriate in this case, as we do not need the broader spectrum that meropenem provides for E. coli. Next slide, please. All right, this leads us into our next polling question. So what is the best empiric antibiotic agent to treat the following rapid diagnostic result? All right, great. So majority of our participants have stated that choice B, ceftazidime avibactam, or choice 2, ceftazidime avibactam, is appropriate empirically for this patient. So just to remember, the isolate is positive for KPC, which is a carbapenemase, and this is a great segue into talking about our carbapenem-resistant Enterobacterales. So our carbapenem-resistant Enterobacterales, or our CRE, account for a significant number of nosocomial infections and contribute to greater than 1,000 deaths annually. So carbapenem-resistant Enterobacterales is defined as an organism that is either resistant to at least one carbapenem agent, or the organism is producing a carbapenemase enzyme, such as a KPC. So here in the United States, our carbapenemase producing isolates account for about 35 to 60% of all of our CRE cases. So the most common is our Klebsiella pneumoniae carbapenemase, or our KPC, our New Delhi metallo-beta-lactamases, or NDM, our Verona integron encoded metallo-beta-lactamases, or our VIMs, our imipenem hydrolyzing metallo-beta-lactamases, or IMPs, as well as our oxacillinases, or OXA48-like carbapenemases. So on this slide, we can see the respective MIC breakpoints defining resistance to our carbapenem agents. And I do just want to point out some verbiage from the IDSA guidance document in terms of what could occur if the isolate is resistant to ertapenem but susceptible to meropenem. So the guidance document states for uncomplicated cystitis that standard infusion meropenem could be utilized. And this is hypothesized as meropenem achieves adequate concentrations in the urine, so likely there will be higher concentrations in the urine compared to other sites of infection. For complicated cystitis or pyelonephritis, potentially utilizing extended infusion meropenem to optimize the pharmacodynamic and pharmacokinetic targets of our carbapenem agents. However, for infections outside of the urinary tract, there is recommendation for extended infusion meropenem. However, alternatives should be explored in this case, as this is a more serious infection. Next slide, please. So different treatment options are available for our carbapenem-resistant Enterobacterales. So for the treatment of uncomplicated cystitis, we have our fluoroquinolones, our trimethoprim sulfamethoxazole, nitrofurantoin, as well as a single dose of an aminoglycoside. For treatment of infections outside of the urinary tract, here we have our novel beta-lactam, beta-lactamase inhibitors, so our ceftazidime avibactam, our meropenem vaporbactam, and imipenem celastin relebactam. So I just want to highlight the different spectrums of activity of these agents, especially for our carbapenemase producing isolates. So for our ceftazidime avibactam or our Abicaz, this is active against our KPC and OXA48 producing isolates. And in comparison, our meropenem vaporbactam, Vabomere, and our imipenem celastin relebactam are active against KPC. However, they do not have activity against our OXA48 like carbapenemases. So looking at our carbapenemases, specifically our metallobeta-lactamase or MBL producing isolates, these are a growing antimicrobial resistance threat as they render all of our beta-lactams inactive, including our carbapenems. However, as trianam, which is a monobactam, is not inactivated by our metallobeta-lactamases and may serve as a potential treatment option. So our metallobeta-lactamases comprise of our NDM, our VIM, and our IMP. And bacteremia due to these carbapenem-resistant metallobeta-lactamase producing isolates is significant. So here we have a study that was conducted in 3 hospitals in Europe from 2018 to 2019, comparing the outcome of patients with metallobeta-lactamase producing Enterobacterales bloodstream infections with either the combination of ceftazidime avibactam plus aztreonam or other active antimicrobials, which are listed here on the slide. So the reason for this combination, it's hypothesized that aztreonam, as it is active against our metallobeta-lactamases, we need to note that aztreonam can be inactivated by ESPLs, our carbapenem-resistant, our AMPCs, so other beta-lactamases can render aztreonam inactive. So the thought is adding it with ceftazidime avibactam that this agent can inhibit the ESBLs, the AMPC, as well as other carbapenemases to allow aztreonam to exert its activity against our metallobeta-lactamases. So this is what the authors looked at here, comparing it to any of these other active antibiotics. Next slide. So what the authors found is in their primary outcome, the 30-day mortality for the ceftazidime avibactam combination was 19.2%, compared to 44% for other active antibiotic agents. And this was shown to be statistically significant. We can also see this shown in the graphic to the left. Additionally, the authors saw that clinical failure at day 14, as well as drug-induced AKI, was significantly lower in patients who received the ceftazidime avibactam plus aztreonam combination in comparison to the other active antibiotic agents. So here, the authors concluded that the combination of ceftazidime avibactam plus aztreonam had a favorable impact on the outcome of patients with bloodstream infections that were caused by our metallobeta-lactamase producing Enterobacterales and may be a suitable treatment option in this patient population. All right, so this brings us to our next polling question, this time a patient case. So we have a 57-year-old male with end-stage renal disease status post-kidney transplant in 2021 who was transferred from an outside hospital. He presented with altered mental status, he was febrile, and requiring vasopressors for hypotension. His imaging showed perinephric stranding and bladder wall thickening, and his empiric regimen at the outside hospital was notable for meropenem 1 gram IV Q12. We can see his microbiology results here with the urine culture and blood culture growing a Klebsiella pneumonia with a resistance gene detection. So the primary team switches to meropenem vaporbactam and calls for your approval. Is this appropriate? And if no, any thoughts on what you would recommend? So meropenem-vaborbactam, as recalling from previous slides, does not have activity against our OXA48 producing carbapenemase. So it would not be an appropriate option to cover for this OXA48 carbapenemase in the organism. However, ceftazidime-avibactam does have activity against our OXA48 and would be a better option for our patient here. All right, so now we're going to go into our difficult to treat Pseudomonas aeruginosa. So difficult to treat, or DTR Pseudomonas aeruginosa, is causing significant healthcare challenges. So there were over 30,000 cases of multi-drug resistant Pseudomonas in 2017 that resulted in almost 3,000 patient deaths. So Pseudomonas has developed multiple and complex resistant mechanisms to fight off our antimicrobial agents. And with the new IDSA guidance document published, there have been new Pseudomonas definitions that came to light. So here on the slide, we can see two definitions for our multi-drug resistant Pseudomonas and our difficult to treat Pseudomonas aeruginosa. So for our multi-drug resistant Pseudomonas, we have non-susceptibility to at least one antibiotic in at least 3 antibiotic classes, so listed here. And then for our difficult to treat Pseudomonas, which poses a healthcare challenge, is non-susceptibility to all of the following. And here you can see many institutions' workhorses for Pseudomonas. So as mentioned, Pseudomonas can be difficult to treat based on its complex resistance mechanisms. And Pseudomonas can exert all of the 4 main mechanisms of resistance that Nicole talked about earlier. So limiting uptake of the drug, modifying drug targets, inactivating the drug itself, or utilizing efflux pumps. So one of the most challenging resistance mechanisms of Pseudomonas is its carbapenem resistance. So Pseudomonas has developed multiple mechanisms of carbapenem resistance, such as the production of AMP-C beta-lactamases. Isolates can also produce carbapenemases, and these isolates are more common, more resistant to treat. So Pseudomonas can also produce metallo-beta-lactamases, such as our VIM and our NDM resistance genes. However, this is more common in Asia in comparison to the United States. Pseudomonas can also alter porin channels, especially our OPRD, which results in imipenem resistance. And Pseudomonas can also modify our efflux pumps, which can reduce meropenem susceptibility. So in terms of the treatment for uncomplicated cystitis, the IDSA guidance document recommends that any of these agents can be utilized. So ceftolozone-tazobactam, ceftazidime-avibactam, imipenem-cilastatin-relebactam, cefiderocol, or a single dose of an aminoglycoside, with no preference over another. For infections outside of the urinary tract, there are similar agents listed here, including our Zerbaxa, Avicaz, Ricarbrio, and cefiderocol. And here, just to note that Zerbaxa does not have activity against our carbapenemases that are producing resistance genes. So when evaluating our different beta-lactam, beta-lactamase inhibitors, they all have different roles in therapy. So when looking at our ceftazidime-avibactam or Avicaz, this agent has activity again against our KPC and OXA48 producers. However, when looking at Ricarbrio, our imipenem-cilastatin-relebactam, this has activity against our KPC producers, but no activity against our OXA48 producers. And then here, just to note, Zerbaxa or ceftolozone-tazobactam has no activity against our CREs. And not listed here is meropenem-vaborbactam, as this should not be utilized in this setting, as the vaborbactam component does not restore any meropenem activity when meropenem is resistant. So here we have clinical data looking at Zerbaxa or ceftolozone-tazobactam in a retrospective multi-center observational study from 2008 to 2010. These patients were treated either for multi-drug resistant or an extensively drug resistant, a similar definition to our DTR Pseudomonas, for greater than 48 hours. And they were either treated with ceftolozone-tazobactam or an IV aminoglycoside or IV polymyxin. So here we can see the clinical cure was higher in patients who received ceftolozone-tazobactam in comparison to an aminoglycoside. And we also see significance with AKI rates in our aminoglycoside or polymyxin group. However, no difference in in-hospital mortality. So ceftolozane tazobactam demonstrated higher rates, and this agent should be used over the other alternatives. So lastly, we have cefiderocol, which is a unique cephalosporin that functions as a sidiospore. So by combining this agent with the sidiospore, we are sort of tricking the bacteria into taking the antibiotic in to allow it to exert its activity. So this leads to higher concentrations of the antibiotic that otherwise would not occur, and it can overcome a lot of different resistance mechanisms. So we recommend that this agent be reserved for our non-fermenting gram-negative pathogens when significant resistance is demonstrated. And for our cefiderocol clinical data, notably, we have the Credible CR and the Apex NP study. So the Credible CR study was a randomized open-label phase 3 trial that looked at adult patients with serious carbapenem-resistant gram-negative infections. I want to highlight about 1/4 of these patients had Pseudomonas infection, and a little less than half had carbapenem-resistant Acinetobacter infection, which Nicole will talk about cefiderocol's role in therapy there. So patients were randomized to either receive cefiderocol or best available therapy, which could have been a combination of 3 antibiotics. And overall, they found similar clinical and microbiologic efficacy with both of these agents. When looking at the Apex NP study, this was a randomized double-blind non-inferiority study of adult patients with gram-negative pneumonia, either hospital-acquired or ventilator-associated pneumonia. And a smaller percentage here had Pseudomonas at 1%, as well as carbapenem-resistant Acinetobacter. And these patients were either randomized to receive cefiderocol or meropenem as an extended infusion, and they found that cefiderocol was shown to be non-inferior in terms of mortality compared to an extended infusion meropenem. All right, so this brings us to our next polling question before I allow Nicole to take it over. So true or false, ceftolozane tazobactam or Zerbaxa has activity against KPC-producing organisms? All right, so we're split here. So ceftolozane tazobactam in vitro has shown to have no activity against our carbapenem-resistant Enterobacterales. So KPC is a carbapenemase enzyme. We should not choose this agent in this setting. And now I will pass it off to Nicole to talk about the last 2 organisms of today's presentation.
Hi, so now I'm going to talk about what we know as CRAB, or carbapenem-resistant Acinetobacter baumannii. Let's see. So these isolates are most commonly isolated from a respiratory specimen or wound, but the clinical challenge here is really understanding whether the organism is colonization or infection. And once resistance to carbapenems has been exhibited, it generally has acquired resistance to most other antibiotics that are normally active against the wild type, which reduces a lot of our treatment options. And resistance to mechanisms associated with CRAB include limited drug uptake, drug target modification, drug inactivation, and efflux pumps. Now, since our clinical data is limited, there is no standard of care for antibiotic treatment for CRAB. One thing to note, though, is that in all our combinations, we should always have unison, just because sulbactam has activity against CRAB. And IDSA guidelines mainly focuses on moderate to severe infections, so therefore they recommend at least 2 agents, where one of the agents must be high-dose unison, and the other agent can be polymyxin, tigecycline, minocycline, and cefiderocol. And now we also have a new novel combination agent called Zacduro, or sulbactam durlobactam, and this was FDA approved back in May of 2023 for HAP or VAP caused by Acinetobacter. Now, sulbactam has direct antibacterial activity, and how durlobactam works is that it has potent activity against the beta-lactamases, including OXA-type carbapenemases. And this restores activity of sulbactam against some MDR Acinetobacter in vitro. And note that sulbactam dosing does differ. So back in the previous slide, Unison had sulbactam at 6 to 9 grams, but with Xacduro, we only need 1 gram of sulbactam because the durlobactam inhibiting the beta-lactamases actually allow more of the sulbactam to reach the penicillin binding proteins. So this is the phase 3 trial for Xacduro that compared its non-inferiority in patients with serious infections caused by Acinetobacter. These patients had some serious infections like HAP, VAP, or bloodstream infections. And so there were 2 parts to this. Part A were patients who could be randomized to either Xacduro or colistin, and part B were patients who could not tolerate or take polymyxin, so they were just randomized to Xacduro only. In terms of efficacy, it was shown to be non-inferior to colistin for 28-day all-cause mortality in crab. However, clinical cure rate was higher at 62% with Xacduro compared to only 40% with colistin, with lower rates of nephrotoxicity, with Xacduro only having 13% compared to colistin, which had 38%. In terms of adverse events, we do see a higher frequency of allergic and hypersensitivity reactions in the Xacduro group, but this is expected for a beta-lactam. So for patient case number 4, we have a 35-year-old male with paraplegia secondary to gunshot wound 4 years ago who presents from their long-term care facility with increased work of breathing, requiring ventilator support, increased respiratory secretions, and fever. Patient has no known drug allergies. So based on the respiratory culture, what regimen would you recommend for monotherapy? Yeah, so most of you got it correct. It was Unison because we would like Unison to have that activity against crab because of the sulbactam component. And it would be 6 to 9 grams. Okay. Next, we'll go to Stenotrophomonas multifida. And the infection rate for Stenotrophomonas has been increasing, and this is due to increasing immunocompromised patients and wide use of antimicrobials. Now, the clinical challenge to this is similar to what we saw in crab, as in when we see this bug, we don't know if it's colonization or infection. This is estimated to be the most common carbapenem-resistant gram-negative bacterial cause of bacteremia in the US. And like all the other bugs we've seen before, it does express multiple resistance mechanisms. We see intrinsic metallo-beta-lactalase L1, which can hydrolyze penicillin, cephalosporins, and carbapenems, but not ACE3 However, it also has inducible beta-lactamase L2, which could hydrolyze ACE3. It's also intrinsically resistant to aminoglycosides, and it also has efflux pumps that reduces its susceptibility to Bactrim, tetracyclines, and fluoroquinolones. And now for moderate to severe S. multifida infections, IDSA actually recommends 2 active agents, at least per IDSA. This comes from the idea that there may be synergy between the agents against S. multifida, but this data may be conflicting. But what we recommend is to do a sequential approach of initiating Bactrim first, and then add a second agent if we don't see a clinical response within 48 to 72 hours. And the agents there are listed. Note that Bactrim could have its own issues of nephrotoxicity or hyperkalemia, so you could consider the other agents as well. And cefiderocol and ceftazidime-avibactam, they can be considered as more last-line resort agents, or patient has clinical instability or clinical failure or intolerance to other agents. And why do we consider Bactrim? It's because it's been the drug of choice for S. multifida infections due to long-standing clinical experience. And now like we mentioned before, the wording for IDSA guidelines mention a combination therapy, but a meta-analysis actually supports monotherapy in these patients. So in HAP patients, we actually see reduced mortality in patients on monotherapy compared to combo therapy, and patients with bacteremia had no difference in mortality rates. So we could actually, that's where you can consider maybe doing monotherapy first for these patients. And now the IDSA guidelines also sort of word against using fluoroquinolone monotherapy, and this is due to the idea that there may be intrinsic genetic resistance in S. multifila, but a study that looked at levoquin monotherapy compared to Bactrim monotherapy actually showed similar mortality rates in patients with S. multifila, bloodstream, and lower respiratory tract infections. So really, you can consider levoquin as an alternative to Bactrim due to the reasons we mentioned before, like hyperkalemia or nephrotoxicity due to Bactrim. And then other treatment options, so we have the tetracycline. So we have minocycline listed here, and it has more favorable in vitro data, but you can also consider tigecycline as an alternative. When using minocycline, it is recommended to use 200 milligrams IV or PO every 12 hours. It has limited use for UTIs, and this is due to the fact that it has rapid tissue distribution following administration, and it leads to poor urine concentrations. And a retrospective chart review that compared Bactrim to minocycline monotherapy showed that treatment failure did not differ significantly, allowing minocycline to be also considered as an alternative to Bactrim. And for the last line agents, like I mentioned before, cefiderocol and AV-CAS plus H3N reserved for more serious infections and reserved it for the end. So patient case number 5, a 31-year-old male with past medical history of asthma, uncontrolled diabetes, and morbid obesity presented with flu-like symptoms and complaints and respiratory distress. He required intubation, which was completed by difficult airway leading to an emerging cricothyrotomy. Prolonged hospital stay, complicated by refractory hypoxia and recurrent infections requiring administration of various broad-spectrum antimicrobials. After multiple courses of antimicrobials, the patients became febrile and had increased shortness of breath and white count. And they were initiated on Marum and vancomycin. And the blood cultures came back, and we have a Pseudomonas that is positive for VIM. So based on the preliminary identification and isolated resistance gene, how would you adjust this patient's antimicrobials? Yeah, so most of you got it correct. It's AV-CAS and H3N, and the reason for this is it's positive for metallo-beta-lactamase, VIM, and AV-CAS has no activity against metallo-beta-lactamases. Okay.
All right, so to finish off our presentation for this afternoon, I just wanted to share this expected activity table with all of our antimicrobial agents that we discussed, as we brought a lot of information to all of you. So this could serve as a quick reference on what organism or resistance gene is covered by which antimicrobial. So green would be active, red inactive, yellow a little bit of a gray zone. All right, so in conclusion, gram-negative resistance is a rapidly growing global health threat where we need novel antimicrobial agents. Organisms may exhibit multiple mechanisms of resistance, either through limiting drug uptake, modification of drug targets, drug inactivation, or creation of efflux pumps. And the treatment of our resistant gram-negative infections depends on the specific organism and if any resistance genes are present. So patient-specific factors, clinical response to therapy, antimicrobial susceptibility data, as well as available clinical trial and primary literature data should be utilized to help guide empiric and definitive therapies. So that concludes When Bacteria Fight Back, a review of gram-negative resistance. And on behalf of myself and Nicole, we want to thank the council as well as the new practitioner committee for allowing us to speak here today. And I know we're running a little bit low on time, but we have provided our emails here, and we will answer any questions via email to all of the participants if there are questions. Thank you.
Thank you very much, Dr. Ondrush and Dr. Capuli, for providing today's webinar. In the interest of time, we are going to skip the Q&A for now, but if you do have any questions, you can submit them directly to Dr. Capuli and Ondrush or to the NYSCHP office, and we'll get you the answers in a timely manner. I am going to read the CE codes now. I think there were some questions about how the CE works. So basically, I will give you the CE codes, and then you should receive an email within approximately 1 week with the links necessary to obtain CE. And if you don't receive an email within 1 week, you can contact the NYSCHP office at ceprograms@nyschp.org.